From the Law Library at the Cleveland County Courthouse, I'm Dave Morris. The Oklahoma Opioid Trial, it's week 3, and it is day 13. And once again on the witness stand today, Dr. Andrew Kolodny, one of the state's star witnesses. He's been on the stand since Tuesday. That continued here Thursday morning under direct examination by State Attorney Brad Beckworth.
Doctor, what do you have to say about that? How did we look in 1999?
It was bad. If you could go back to 1996, we didn't have any problem. It was bad in 1999. There were states with a problem that was emerging, but had we responded appropriately, had opioid manufacturers, had Purdue Pharma and Johnson & Johnson said in 1990, I guess this is 2001, had they said in 2001, gee, there's a problem with the increase in prescribing, it's leading to adverse public health consequences, we should stop encouraging aggressive use, we should stop giving money to organizations that are promoting opioid use. Had they just pulled back when it was clear that we were experiencing a public health problem caused by opioids, I firmly believe the epidemic never would have gotten as bad as it did. For one thing, many people use the term addiction and dependence interchangeably. And so what a doctor should tell every patient is that if you take an opioid around the clock every day for as little as 5 days, you are going to become physiologically dependent on the drug. You will likely feel uncomfortable when you discontinue the drug, and that the longer you take the drug and the higher the dose, the more difficult it will be for you to ever come off of the opioid. Physiological dependence is not necessarily identical to addiction, but it's closely related. With regard to developing addiction, the answer should be, I don't know what your chance of becoming opioid addicted is. There is no way to predict in advance, but this is a highly addictive drug, and evidence suggests that patients who take it long term, that more than 25% are likely to be addicted.
Is addiction difficult to diagnose and treat, or can it be?
Addiction is very difficult to diagnose because, as I mentioned, a patient who's suffering from opioid addiction and knows that they're addicted is likely to be very ashamed. There's a stigma with the disease of addiction. So a patient who may have started off taking opioids as prescribed by a doctor, but now is craving them, may be taking extra doses, may start engaging in what is sometimes termed doctor shopping. They're going to feel very embarrassed by that, and they may not recognize that they've developed a disease caused by repeated exposure to a highly addictive drug. They may feel like there's something wrong with me, and so the patient will be ashamed, and that's one reason it's difficult. The other reason it's very difficult to diagnose is once somebody becomes addicted, their life will revolve around maintaining their opioid supply to make sure that they don't run out. So that patient who's visiting a primary care doctor for the prescription will often do everything they possibly can to hide from that doctor that they're addicted. Whatever they need to say to the doctor to be able to walk out with the prescription, they'll say. If the doctor needs to hear that their pain is well controlled in order to get the prescription, they'll say my pain is well controlled. If they think the doctor needs to hear that their pain is getting worse, they'll say their pain is getting worse. The last thing they want to do is jeopardize access to a legitimate supply, because what will that mean? That might mean turning to the street or having to line up at a methadone maintenance clinic. Another reason that it can be difficult to diagnose is that a patient may be addicted and not know that they're addicted. You see that more with other drugs, like alcohol addiction. You're more likely to see people with severe alcohol addiction and not know it. But so for a variety of reasons, it's extremely difficult to detect addiction in patients on chronic opioid therapy. And this is the very last, it's not even, I can't even say it's the last thing we should be doing. We should never do anything like this. I don't know for certain, but this suggests that Johnson & Johnson paid for that long lunch and plans to pay for dinner for Lloyd on July 24th. And as we talked about previously, there's a study that shows that that type of payment for lunch and dinner influences prescribing, and that the opioid crisis is more severe where more prescribers take that lunch and dinner.
And it goes on to talk about showing the Simpson study and bringing the doctor's comfort level up for higher doses when necessary, right?
Yes, it does.
And then here it says, Lloyd coaching, want him to be more comfortable using DUR and dosing it higher.
Yes.
Doctor, based on your experience and qualifications, is that type of messaging here in Oklahoma okay?
No, it's not okay, and I believe that Johnson & Johnson heard that it's not okay from the FDA when they received a warning letter for using these studies. I think Oklahoma is doing some pretty good work right now trying to get those messages out, but we need to do much more since so much was done deceiving the medical community about the risks and benefits of opioids.
Here in Oklahoma, to abate this crisis, can you tell the court whether we need counter-detailing and pervasive, extensive re-education of everyone involved in the prescription opioid business in Oklahoma?
They are critical components to an abatement plan.
It's expected on Thursday afternoon. The state's examination of Dr. Kolodny will wrap up. Then we'll have some cross-examination from attorneys from Johnson & Johnson. You can follow along at oklahoman.com. As always, Randy Ellis is reporting from inside the courtroom. You can follow his coverage every day in the Oklahoman and also online at oklahoman.com. From here, the media room, the law library at the Cleveland County Courthouse in Norman, I'm Dave Morris.